is walking. It's flat. And after that, midline. Second variant. Symmetrical parts. You can use one variant. It's not important to use two. Clear? And after that, your conclusion. Abdomen is soft, not painful. And that's all. Okay. Questions? No questions?
Can you tell the differences, if he has a lump in the abdomen or some kind of a mass that it is palpable, so how do we palpate, check for the quality of the tenderness and the movable with the respiration?
Wait. You're talking about mass, yes? Okay. Let's imagine. In left inguinal region, during superficial palpation, I palpate mass. The diameter of this nodule, for example, it's possible to say, maybe it's nodule, yes, or mass, is 3 centimeters. It's not painful. It's soft or hard if you are talking about consistency. It's movable, and that's all. If you are talking about where is it, what is it, it's possible to say. If not, maybe mass. It's possible to use extra methods to check what's going on. If you think this is lymph node, you can say lymph node. If it's not clear for you what's going on, what is sitting here, it can be like pathological mass, and that's all. Size, consistency, and pain. Yes. Is it possible to move it? That's 5 positions. Same with lymph nodes. Where is it? What's the diameter? Is it flexible, or maybe it's conglomerate together with tissues? Is it soft, hard? I'm talking about consistency. And size and pain. Where is it? Size. Where? Where? Oh my God. Size. Where is it in size? Consistency. Movable or not? Pain? Yes, no. 5 positions. That's characteristics. That's answer? Was it question?
Yeah. Ma'am, if it's movable, what are the variants we can imagine?
Once again, not clear for me.
If the lump is movable, so we can move it superficially. So what are the pathological situations we can imagine?
We cannot imagine if you palpate only. We want to have extra examination because variants are there. We don't know what is it. Maybe it should be extra examination. Variants, first variant, it can be ultrasound. Maybe it's possible to talk about structure. It can be punction. To check what's going on. What is it? Biopsy. I don't know. It's variants are there. Even it's possible to have lymph nodes. It's possible to have a mini surgery, to have this speck of lymph nodes to find something pathological. Okay. Deep palpation. What do you know about deep palpation?
Organ borders.
Maybe organ borders. What else? It's possible to palpate organs. We use spatial algorithm of this palpation. First of all, direction. We'll start with sigmoid colon. After that, you'll palpate second in practice. After that, ascending, descending, transverse colon, and lower border of the stomach. Yes? No? Okay. If we are talking about algorithm, first we want to talk about proper breathing for us. That's why we should explain these details for patient. This is my hand. During inspiration, your abdomen will go up with my hand, and during expiration down. Look at me. Up, abdomen, down, up and down, abdominal breathing. Correct. Now, you will go parallel to intestine, to sigmoid colon. That's why. For sigmoid colon, we imagine line between umbilicus and spina iliaca anterior superior. This is line. You divide this line by 3. And the position of the sigmoid colon will be at the point, it's not for all the patients, it's not possible to have, it's not mathematics, between middle and lower part of this line. Once again, umbilicus to spina iliaca, 1, 2, 3. You'll go to this point between middle and lower part of your line. Position of your hand closest to me, closer to me. Parallel to sigmoid colon. This is first variant. It should be comfortable for you. This is second variant. For me, comfortable will be this variant. If you are a left-handed person, you should sit opposite. You will walk with your left hand. And your position will be like this position, yes, if you'll sit there. I prefer this. After that, abdominal breathing. During inspiration, you'll go to umbilicus. Look at me. This is sigmoid colon. This is umbilicus. Yes? Sigmoid colon, umbilicus. This is our line. You are staying parallel to this colon. During inspiration, you'll go to umbilicus. It will be skin fold. Skin will go to umbilicus. Breathe in. During expiration, breathe out. Your fingers will go down and you will palpate sigmoid colon. Breathe in, out, and palpation. Breathe in, out, and palpation. Hand is soft. Breathe in, skin movement. Breathe out, and palpation. Do you feel? It's not very comfortable, but not painful, correct? Of course not. It's easy because patient is thin. That's why it's not big problem. In practice, problem can be if patient is very big and muscles are very strong. Sportsman. If patient is big, sometimes abdominal wall is very soft. It's possible to go deeper. But if it's huge abdomen, of course not. What should you write in your case? If we cannot palpate sigmoid colon, for example, a second. Clear? Breathe in, breathe out, and palpation. Who wants to try? Okay, maybe I'll show all the steps, and after that, because I should give you time to try. Next class, you'll show me. Next, second. Spina iliaca, umbilicus, line, 1, 2, 3. Point between lower and middle part of this line. It's average, that's why you can shift your hand. You'll try this point, and after that maybe upper, lower, to find this second. I didn't say about characteristics. If you palpate colon, what should you say? Size, for example, this is soft consistency, tube, movable, with diameter 1 centimeter. Not painful. Clear? Same for all the intestine. It's not comfortable for me. Okay, breathe in, breathe out. Did you feel? Once again, because I found breathe in, breathe out, and palpation. It should be. It's slower. Oh. It's even not important to go deeper because it's sitting superficial. Clear? Ascending column. You use both hands. One hand will be like table for you. You should fix back because it's too soft. Normal position. Okay. After that, you'll go maybe 3 centimeters from umbilicus. This is our line parallel to intestine. Breathe in to umbilicus. Skin fold. Out. Oh no, nothing. Once again. Closer to peripheral parts. Out. Maybe, not clear for me. Clear? If not clear, what should you write? I didn't palpate ascending column. Descending. Mhm. Same story, to umbilicus, out, and palpation. I didn't feel, once again. And out, and palpation. Clear? Transverse colon. If you want first inferior body of the stomach, we first of all we use percussion or auscultation to find inferior body of the stomach. How can we do it? If we are talking about abdominal percussion, what's the sound? Tympanic. We'll go from high tympanic to low tympanic. Stomach is bigger, can give us low tympanic. Intestine is smaller, it's high tympanic. Look at me. And this is our line. It's rectus muscle border. See? It will be inferior border of the stomach. After that, you'll go 2 centimeters down. It will be level of transverse colon. This is first variant to find inferior body of the stomach. The second variant will be auscultation. Who has stethoscope? Come here. Position of your stethoscope will be, this is costal arch, this is border of rectus muscle. Here will be, like, you cross costal arch and this border of muscle, and here will be position of your stethoscope. If abdomen is small, you can use stethoscope for children, for example, or you have smaller stethoscope. Yes, I'm talking about bell. But if you want to have loud sound, the best variant can be bell. Yes, and look at me. When sound will be louder, this is inferior body of the stomach. Here, that's too low. Let's try. It's over here. Okay, here. It's level of percussion, our percussion, once again. Yes. Oh, this is stomach bottom, correct. Clear? That's why 2 variants. We have 3 variants, but it's enough. It's possible to use 1. Sometimes percussion doesn't give us information about this sound. It's not possible to find. High and high, or low and low. For example, if patient has bloating, it will be low. Low tympanic everywhere. It's not possible to find. That's why you use stethoscope. Clear? 2 centimeters down by manual palpation. If patient has not strong muscles, you can place your hands close to umbilicus. If muscles are so strong, laterally. Okay? Breathe in. I'm going to epigastrium. Breathe out. And palpation. It's down. Breathe in. Breathe out, and palpation. Clear? It's possible to feel sounds even. And after that, characteristics. If we are talking about lower body of the stomach, you should know technique. But in practice, we don't palpate this lower body. Do you know why? Patient should be cahectic. If you want, it should be very deep palpation, and patient should be so thin if you want to palpate this lower body of the stomach. Because in your book you have palpation of pylorus too. Yes, I think. Where is this pylorus? Line, midline, and after that a 90-degree angle. And this line in this angle will be line for pylorus. But we don't palpate pylorus in everyday practice. Because if it's pylorus, it's possible to palpate it. Patient should be cahectic. It can be pylorus stenosis. Stomach should be huge, maybe. Or it should be pathology of this stomach. I don't know, tumors, maybe. It's possible to palpate this, something special if you are talking about this cahectic patient. But if the structure of abdomen is normal and subcutaneous fat is present, It's not possible to palpate pylorus or lower border of the stomach. We use endoscopy to find something inside. Clear? How can we do it? Breathe in. We found, we used percussion or palpation. We found this inferior border, and after that breathe in, breathe out. And you'll go deep, very deep, and after that palpation. Clear? For inferior border of the stomach. Breathe in, out, and palpation. I didn't do it. I showed you how, because it should be very deep, it's not comfortable. And same with pylorus. Breathe in, and after that out, and very deep for palpation. Clear? Do you have questions? That's why in practice, sigmoid, secum, ascending, descending, transverse. Sometimes lower border, pylorus. I think that's all.